Thank you very much, Roald. As always, a tremendous presentation, and we're asking for the microphone. Roald, I think you're running away from the microphone, gentlemen. Thank you. So it's a great pleasure to introduce the next section. And before I do, I remind us all that this conference is a collaboration with IHF, the International Handball Federation, and Aspetar. And I want to pay tribute to my co-chair, and that's František Čerborský, and he's from Czechoslovakia, and he is the IHF Executive Committee. And if you could stand up, please, that'd be great. Thank you very much.
Forward. Yeah.
And František was a top player in Czechoslovakia and a professor of physical education and a great advocate for injury prevention in handball, and he's here with the executive of IHF, as you know. So we've got two speakers to share the next section on dental injuries, as you can see. Peter Fine is a pioneer in sports dentistry, and it's amazing how bad the teeth of athletes are, as you see, and what an important opportunity for public health promotion that will be. And he will be partnered with our own Dr. Mohammed Al-Say from Aspetar. And Dr. Mohammed Al-Say is the head of sports dentistry at Aspetar. And he was trained in Germany, and he's part of the Deutsche Bundeszahnarztkammer, and the last word is Arbeitsgemeinschaft. And that's the Zahnarzt Arbeitsgemeinschaft, that's the dentist group, German trained. So we're looking forward to having both of them share the microphone. And Peter, if you want to come up first.
Thank you. Thank you very much, Mr. Chairman. Ladies and gentlemen, thank you very much for the organising committee for this opportunity to perhaps give some of you an introduction towards dentistry and the traumas that we see in sports, and looking at handball particularly. I'm not sure after the last speaker whether I've got mild concussion or whether I'm actually ready to talk about this, but hopefully it will give you a little bit of knowledge about what we do in sports dentistry. This is the university which I hail from in London, in England. What I wanted to do today was to take this opportunity to give you a little bit of introduction into sports dentistry and look at the prevalence of some of the injuries, particularly with respect to handball, obviously at this occasion. And then we'll look at the orofacial injuries generally, and my colleague Dr. Mohammed Al-Say will show you some of the dental injuries that we have to deal with. But in keeping with other trends in the conference, I want to have a look at prevention as well, because a lot of the trauma that we see and a lot of the disease that we see is certainly preventable. And also something else that I've got out of the conference is the need for screening, which we'll talk about a little bit, hopefully, if we have a chance to do so. So I was involved quite heavily with handball at the London 2012 Olympics. I was fortunate enough to be in the arena for two and a half weeks of the competition, and it was my introduction to handball. I'd not seen it before. I found it thoroughly exhilarating and exciting. But there was very little dental trauma. Thank goodness, many of you would say. Most of the stuff that I had to treat was soft tissue damage. The only hard tissue trauma that we saw was one of the chefs in the kitchen who managed to break a filling when he was tasting some of the food that he was preparing. Otherwise, it was just soft tissue injuries that we had to deal with. But it was an opportunity to be part of the medical team. And certainly, the medical team there consisted of sports medicine consultants, consultant anaesthetists, physical medicine people, trauma nurses, and dentists as well. I was one of 3 dentists who covered the whole of the Olympic event. So it was a great opportunity to look at handball and enjoy it. But handball, as I say, does not feature very heavily in the degree of trauma that we see to dental tissues. But as I'll show you in a few moments, hopefully, even though there's only a few cases that we've seen, those cases are quite significant and quite important. So this paper was published back in some time ago now, 2003, and it was done in Nigeria in Africa. And it looked over a period of a sporting occasion, and the only handball incidents were once again soft tissue trauma, namely lacerations to the face. But this is a more prevalent study, really, a more reliant study, because this group, Professor Lang in Switzerland and Germany, looked at the incidence of handball trauma in both professional, semi-professional and amateur groups in Germany and in Switzerland. And as you can see from the graph on the right here, there's very few incidents. This is a chart that shows basically the response of those athletes as to whether they were experienced of dental trauma, whether they'd had a trauma themselves, or whether they actually seen trauma in the handball arena. And there was only a handful in both countries had actually witnessed any dental trauma. So the incidence is quite low. But nevertheless, the incidence, when it does happen in sport generally, can be quite catastrophic. And of course, we still use the René-Lefort classification of fractures, the Lefort 1 here, Lefort 2, the pyramidal fractures, and Lefort 3. And if you see one of these cases, which do come to us from time to time in the department, we look at this, and the whole of the premaxilla is movable. It needs, obviously, surgical intervention and fixation, and going right the way through to the 4-3, where literally the whole of the maxilla is movable. The other traumas that we often see in the sporting arena are nasal traumas, and these are either lateral displacements or compressions of the nasal structures. The areas that are really quite prevalent, and the ones we see most of all, are those that involve the zygomatic process, and then secondly, the mandible. The mandible, the most common areas of mandible problems that we have are the angle and the body. And one of the reasons that it's particularly prevalent in this group of athletes is the position of wisdom teeth here. And although this chart doesn't show the roots of the wisdom tooth will end up somewhere down in this sort of area here. And athletes who either have wisdom teeth or who electively have wisdom teeth removed end up with quite a small amount of bone and quite a weak lower border. And so not very much trauma will result in a fracture of that angle of the mandible. And this is particularly important in this group of athletes because wisdom teeth generally come through between about 18 and 30. It's exactly the sort of age of athletes that we're looking at. And there was an incident in the Beijing Olympics where one of our British rowers developed an infection in the wisdom tooth about 4 weeks before the event. And to take the wisdom tooth out would require fairly major surgery. So it was decided not to do surgery, but to give him high doses of antibiotics, anti-inflammatories, that deal with the infection that way. Of course, the problem with that was that he then became quite low and couldn't train, ended up, instead of winning a medal as he was planned to do, he ended up not even getting into the final of the rowing event. And this developed a theory with the British Rowing Association that all their oarsmen would actually be screened for wisdom teeth before they actually went anywhere near an event. But we have problems with that because we don't now electively take out wisdom teeth. There are complications from the surgery that we don't need to go to with the vast majority of the population. But dealing with elite athletes, we need to perhaps rethink that and decide whether elective surgery on these potentially impacted wisdom teeth is the right way forward. But fractures, we see quite a lot. We see quite a lot in the sporting field, but we also see quite a lot in day-to-day life. And we're looking particularly at the signs being bleeding, difficulty in opening the mouth widely, obviously bruising and stiffness, and numbness of the face, particularly on the lower lip, where there's potentially damage to the inferior dental nerve, which is a branch of the trigeminal nerve. Likewise, in dislocations, the patient often feels they can't actually bite their teeth together properly, and this is an indication. And dislocations can be quite readily and easily reduced, either pitch side or in the surgery very soon afterwards. The sooner it can be reduced, the better, because then we don't get so much trismus in the muscles, which then may lead to the necessity for muscle relaxants and so on. Inability to close the mouth is another problem. And the teeth don't line up properly. And if you've got someone who you think may have dislocated their jaw, if you ask them to try and close their teeth together and they can't, then that's generally a sign that they have actually dislocated their jaw. Okay, what I wanted to just show you here was comparison with some other injuries. American football, you would think, would be quite a large proportion, a large percentage who would have dental trauma. But because they wear such a lot of protective helmets and shields and mouth guards, the actual amount of trauma is far less than in handball, which has relatively quite a few amounts of trauma to the dental alveolar area. So we need to be thinking about perhaps some sort of preventative measures, which I'll talk about in a moment. Just to complete the statistical part, the type of injuries that we see in handball are avulsions. Avulsions are primarily when a tooth is completely knocked out. Crown fractures speaks for itself, and dislocation. And dislocations are when a tooth is actually moved in its socket. It can be replaced. And I think that's probably a good point to hand over to my colleague, Dr. Al-Sai, who's going to continue with the next bit of the presentation. That's forward, that's backward. Okay?
So I'm going to talk about the different types of tooth injury that can happen during the handball competitions. So the first type, it's called the crown fractures. This one is one of the most common dental injury that can happen during the handball games. And this type of injury can occur in different ways, starting from crown and fractions, or it's called enamel grazing. This type of injury actually require no treatment, just you need to keep the tooth under observations, and you have to do a vitality test. The second type of injury, as you see in my slides, there is a fracture of a small piece of the crown, and this type of injury, it's called enamel fracture. And the line of treatment is just to place composite filling. There is also another type of injury. It involves the enamel and the dentine. It looks a little bit quite bigger than the previous slides. And the difference between enamel injury and dentine fractures, in dentine fractures, the patient always complain from sensitivity. So usually this type of injury is treated by placing of desensitizers, followed by composite filling as well. The next type, it's called a crown fracture involving a bulb or a nerve. This type of course of injury require root canal treatment followed by post-crown. The second type of injury, it's called root fractures. The two slides in your right side, it is actually for a handball player that was seen in our department. He received a trauma a few months ago, and he was playing the game without wearing the mouth guard. After several types of x-rays, we took also intraoral x-ray or periapical x-ray film. We found a big fracture almost in the middle of the root. Of course, here the decision was removal of the tooth, followed by either dental implants or dental bridge. This one, it's called tooth intrusions. And this type of injury, it occurs when the athletes receive trauma in the lower anterior part of his jaw. The result is the upper anterior tooth can be partially delivered into the alveolar process. And when you take X-ray, you will find the root is a little bit elongated or deeper than the next one. The treatment of this type of injury, it requires to do the following. Number one, you have to do repositioning of a tooth, followed by using fixations of a tooth by using titanium splint. Sometimes you need to do orthodontic extrusions. But remember, the treatment must be done quick to avoid bulb exposure, bulb necrosis, sorry. Next one, it's called tooth extrusions. This one of this type of injury can occur when the patient or when the athlete received a trauma in his upper anterior area. You will see the tooth knocked partially outside the socket. And when you take X-ray, you will find the socket is empty and at the end. And the treatment, it should be including the following. First of all, you have to do repositioning of a tooth. Then try to keep the tooth out of the occlusions to reduce the load or the pressure on the tooth. We use a non-rigid splint for roughly 2 weeks. After removal of the splints, we have to keep the tooth under observations, and we have to check a vitality test. And if the tooth is not vital, then require root canal treatment. The other one, it's called avulsions or completely knocked out tooth. This type of injury, it's one of the most dramatic sports-related dental injuries. And in this type of injury, the tooth will be knocked completely outside the socket or the oral cavity. And my question is, can this tooth can be saved or treated or not? The answer, of course, yes. But time factors, time plays and major factors on the repositioning of the tooth. And all the studies shows that the rate of the success can reach around 90% if the tooth replanted in the socket within 2 hours. But how the national team doctors and the club doctors should deal with this type of injury until they transfer the patient to the dental office. First of all, you need to hold the tooth. First of all, of course, you need to find out the tooth and try, please, to hold the tooth from the crown. Don't touch the tooth from the root area, because that will lead to damaging periodontal fibers. If the tooth is dirty, try to wash the tooth under cold water for roughly 10 seconds. Then you need to give the instructions to the patient either to keep the tooth or to fix the tooth inside the socket and request from him to bite slowly on the tooth. If that's not possible, try please to keep the tooth in the lower molar, in between the lower molar area and his cheek. This area is called the buccal sulcus. But if you are afraid that your athletes will swallow the tooth, then try to keep the tooth in a suitable liquid. And the best liquid for that is milk. Why milk? Because milk is bacterial free, and the pH of milk is almost the same like the oral cavity, which is almost 6.6 or 6.7. Then please translate the patient immediately to the nearest dental office. I'm going to show you also one pictures for a basketball player. He was received trauma and he was playing the game without wearing the mouth guard. And the result, his upper central tooth completely knocked out the socket. And the line of the treatment, we try to reposition the tooth in the socket and then using titanium splint for a couple of weeks. After that, we remove the splint and we have to check the vitality of the tooth and the mobility of the tooth. Thank you.
Okay, this young lady got injured at London 2012 Olympics in the handball arena. But what I wanted to just look at on the slide is what a lovely set of teeth she's got, despite the fact she's not wearing a mouth guard. And we're talking about mouth guards, talking about prevention. And one of the most important aspects to this, I think, is that the cost of treatment. And of course, very often with dental injuries, the cost of treatment is not just for the first few weeks or months while the process is healing, but it's a lifelong process. And many of these athletes who do suffer from trauma will actually be paying for dentistry for the rest of their lives. Many of you who've had dentistry done know that we haven't yet developed materials and techniques that last forever. You often have to have things replaced. The soft tissue injuries that we saw at the handball arena were mainly, all lacerations in fact. And much the same way as with most surgeons, we would use 4-0 silk in the oral cavity, and on the face we'd use 6-0 silks as well to repair those. Some of them needed subcutaneous sutures first of all, others just needed superficial suturing. But I want to talk a little bit now about the preventative side of things and look at the position of teeth, a little bit on mouth guards and a little bit on the diet as well. Position of teeth is quite an important case, particularly from the younger players. So on the top slide here, we can see this young player, probably about 8 or 9, 10 years of age maybe, with a large gap between the top and the bottom teeth. And the problem with the position of those teeth is that they're getting no protection from the lower lip. And the lip is a really helpful protector to teeth. So with a very simple orthodontic appliance, which had been fitted on this one here, the teeth have been moved backwards, they've been moved into a much safer position where the lower lip can help protect those. But this is obviously done by a specialist. But with younger players that you may be coming across, particularly your own children or in schools or clubs, this is quite an important preventative measure that can quite easily and cheaply be carried out. Mouth guards obviously, but there's mouth guards and mouth guards. We at the Olympics made just over 200 mouth guards for the athletes who came to London. Some of them had not had mouthguards before, some of them had lost them, some of them had forgotten them. But we made just over 200 for various sports, including handball players. And this is a sort of good shape to a mouthguard. One of the problems with mouthguards is that athletes very often don't like wearing them. They say they're uncomfortable, they fall out, they can't breathe. But something properly constructed, well-fitting, this is what we call a laminate. It's 2 layers. We vary the layers depending on the sport. Handball, we normally make just 2 layers of laminate. And the important thing is that the lower teeth actually fit in to a predetermined bite on the surface of the mouthguard. And that's important because what's happening here is not only are we getting some direct protection to the teeth, particularly the upper teeth, and we know from the literature that the upper teeth are the ones that take most of the problems, we're also getting some protection from the temporomandibular joint. Because if the teeth are together and they're fitting together well, then we don't get lateral forces going through the mandible and potential risk of that joint. What we don't know, and the jury is still very much out, is whether wearing a mouthguard actually prevents concussion. There are papers that say, yes, it does, and there are equal number of papers that say it doesn't. And a study by Bligenot in France in the 1980s looked at different types of injuries, different types of orofacial dental injuries, and actually determined that there was an equal distribution of trauma between those athletes who wore mouthguards and those who didn't. But I think the feeling these days is that it perhaps doesn't prevent neurological injuries, concussion particularly, but the value of wearing the mouthguard is plain to see. But the other sort of damage that we get to teeth and trauma to teeth is a much slower process, and that's erosion. And erosion particularly coming from sports drinks. Sports drinks are very prevalent these days. The acidity of them is extremely low. Some of the more common ones are around about 3 on the pH scale, so very acidic. Not quite as acidic as Coca-Cola and Fanta and things like that, but approaching that. And the problem with these drinks is that athletes are consuming vast quantities of them all day, every day. There have equally now been some studies that suggest that milk is a much better fluid to rehydrate with. And clearly, as my colleague was saying, it's virtually neutral in terms of pH. So perhaps we ought to be encouraging the athletes to use milk as a recovery drink rather than using some of the more well-known proprietary brands of sports drinks. We also find now we have a large group of patients, particularly young female athletes, middle and long distance runners particularly, who have problems with gastric reflux. And this is causing a lot of erosion of teeth as well. And these problems are repairable, but once again, the patients have then got them for life. So what we're looking at now, following on from London 2012, is ways of screening elite athletes. And we're now looking at professional soccer players in the UK. We've got about 10 of the top clubs in the UK now signed up, and we're going round and we're doing pre-season screening of all their players. That's from the young players, the sort of 11, 12-year-old players that they've got in their academies, right the way through to the senior international players. And the screening involves looking for dental disease, giving them preventative measures, general health advice as well, continuing that educational process. But it's also looking at we're also starting to look at saliva and the influence that saliva has, and early detection of dental disease. This was a study that we did at London 2012. Professor Needleman, who's my colleague at the Eastman, was heavily involved in running this study. And what it looked at was the dental disease of elite athletes at the Olympics. The study was over 300 athletes attending the clinic, the dental clinic, during the course of the Olympics. And we found that some of them had up to 14 active cavities in their mouth. Now, these are elite athletes from around the world, including handball players, who had spent years preparing for an Olympics, and yet nobody had looked inside their mouths. And very many of them had a huge amount of active decay. What we're looking at now is how we can screen these athletes in a more effective way so we can get at them before the problems start and try and prevent them from getting problems. The study looked at not just caries, dental decay, which is still the most prevalent disease in the world, but it looked at gum disease, it looked at erosion, and trauma as well. Okay, almost there. So one of the things that we're looking at particularly now is saliva, because saliva naturally washes the teeth, and it's extremely good in its good phase, extremely good buffering capacity against the acidity that occurs in the oral cavity. So we're looking at saliva flow rates for athletes, which is often quite low. We're looking at their general levels of hydration. The consistency of saliva is very important, and any medication that they may be taking which may influence the quantity of saliva that they're actually producing. And we can advise on saliva substitutes, as well as looking at why they're getting a reduced flow of saliva and perhaps influencing that as well. Thank you very much. I'll take any questions. I've got a few minutes?
No, you haven't.
No, we haven't. Oh.